All right, so we want to welcome everybody to our bariatric seminar. My name is Jeff Hannon. This is a beautiful picture of downtown Mobile, which is where we are located today. We want to welcome our Facebook participants today. It's our first Facebook Live seminar, and we want to make sure that everybody has a chance to hear what we're saying. Can everybody in the room hear us okay? All right, good. And so I'm mic'd up for the audio on the Facebook. This is a seminar about weight loss surgery. So if you're in the wrong place, now's the time to say. But what we're going to talk about is obesity. Why would you consider weight loss surgery for obesity? I think that's a key question, because your family and friends sometimes will ask you that. Why in the world are you going through surgery to lose weight? We'll go over that. We'll talk about the pros and cons of the surgical options. Basically, we offer gastric sleeve and gastric bypass. So we don't just offer one thing. So I think you need to have the differential between those things. What's the reason that you might pick one over the other? We'll talk about insurance a little bit. I'm not the best source of insurance information, but we do have a whole office here in the building that deals with insurance and patient financing problems. We have plenty of time for questions. I'd like to encourage the Facebook people to send in their questions to us over Facebook. Those of you here in the audience, what I'd like to do is ask you to wait till the end, if you would, to note your questions on your paper, and then we'll talk about all the questions at the end of the presentation, because I've found over the years that a lot of times, people will ask things and then we'll already have it covered later in the talk, and so it just works better if we just kind of wait till the end to go over all the questions. I do want to say, though, we're not really going to get into any specifics like particular patient diagnoses or particular situations with patients, because this is on the Facebook, and there are a lot of federal laws that cover any kind of health information being released over the internet or anything like that. So we're going to be very generic about our questions and answers that go out over the internet. So I want to just remind everybody about that, to keep your questions non-specific. I can't really talk about your specific diagnoses and things like that. We would want to really talk about just generalities. And then we'll, of course, have a lot of opportunity to go over the next steps to make sure that everybody understands what the next things are to do to get you some help with your problems. This is all about what's right for you, okay? I always have to answer the question when I see a patient in the office, doctor, what would you do? Well, it doesn't matter what I would do, okay? I understand the question. That's a very good question, but it's really very important to know this is not about me. It's about you. And the reason we offer more than one operation is because there are differences, and some of those operations are better for one person than the other based on your expectations, your lifestyle, and what you need. And so we'll talk about why those things are different. But this is all about you. I think you need a fund of knowledge before you even start investigating this. Sometimes people think that they know what they want, and then they hear the seminar, and a lot of times it changes your mind. So keep an open mind until you get to the end. Again, save your questions to the end, and then I'm going to be around for the audience here in the room, and we'll also be around to answer questions online. We are the Surgical Association of Mobile. They call that SAMPA, which is just an abbreviation. We're also the Gulf Coast Bariatric Institute. Both those things just mean the doctors and the people in this office. There's 7 surgeons here. I have been practicing since 1984 doing bariatric surgery. I've got a partner who was practicing since the 70s. We've had many years. I think we totaled it up a few months ago or something. We had I think it was almost 9,000 patients that we've helped with weight loss. So this practice has a lot of experience with weight loss surgery. We're all board certified by the American Board of Surgery. And we don't only do bariatrics or weight loss surgery. When I say bariatrics, that's really just another term for weight loss surgery. We don't only do that. Today I've done a cancer operation. I've done a weight loss surgery already. We'll also do gallbladder surgery, hernia surgery, colon surgery, a lot of abdominal type surgeries, almost all of it done through the scope with either laparoscopic or robotic technique. And that's what we concentrate on. Obesity. Everybody, that's a catchphrase. Really, it's a disease, though. It's not just a It's just not something you talk about. It's a disease. It's got its own specific diagnostic criteria, its own specific consequences that happen. It's a disease of too much body fat, and that results in health problems. It's caused by a bunch of different things. It's not just one factor that causes obesity. If it were, it'd be a lot easier to treat. It can be genetic. You know, there are genes that tend to make you a weight similar to your siblings or your parents. So you'll see that when you look at a family. You know, if you take family photographs, you say, well, everybody's kind of the same size in that group. So that is something that's genetic. It also has to do with your metabolism, your exercising and eating habits, your surroundings. There's some studies that show that, you know, that twins that are separated at birth will tend to be the same weight unless you put them in places that have completely different numbers of McDonald's hamburger stands. Okay, so your surroundings do make a difference. And then there are psychological factors. Okay, so we are aware of all those things. If you're walking down the street and you look at patients walking, you know, out Christmas shopping, you can kind of tell who we're talking about. We're talking about the severely and morbidly obese patient. Okay, and the way we look at that is with a BMI, body mass index. A body mass index of 35 or greater with comorbidities, we call them, or 40 or greater without comorbidities are candidates for intervention. There are some surgical procedures that would leave you as a candidate with a 30 BMI or greater, and we'll discuss that very briefly. Very common problem, you know. You don't really need me to tell you that. This is something you see everywhere. Over half the population is obese, and a significant portion of that, about 10% of the whole population, is morbidly obese. It's a little higher than that now since this slide was made, but it's very common. Now, of course, we're never going to operate on 1 out of 10 patients in the United States. We just don't have enough surgeons, enough hospitals. So if you do decide to have this surgery, you're part of the elect. You're part of the few that do get this done. There's also a problem with overweight children. We don't operate on children here, though, but it is a very significant problem right now in the United States. If you look at the numbers, these are from the Centers for Disease Control, and you just watch down in our area of the country. We stay in the middle of the problem, and they keep coming up with new colors for how big the problem is. Basically, you look, and we're in the middle of the area: Louisiana, Arkansas, Mississippi, Alabama, and then West Virginia is included with us. Up to a third or more of the population of these states are having significant problems with obesity. But you know, they say that you could take this map and make it into one map that shows the rest of the country, and then a little circle around Los Angeles and a little circle around New York, and maybe Colorado, and those are too small and the rest of us are too big. So, you know, it's really a very common issue. What does it do? Well, there's some psychological issues. We talked about that. You know, people that have problems with their weight, they have a lot of negative self-image, they have social discrimination and isolation. And, you know, there's some good studies out there, scientific studies that show that that is a true fact. It's not just something perceived by the patient. People really do have problems socially with their weight. And I've seen those in my office a lot. I tell everybody, you know, these are the things that are kind of in addition to everything else. This is the things that we deal with that are probably not the primary thing that we deal with, but we see a lot of this in our office. Day to day is just hard for patients that are overweight. The whole world is not built for you. You know, you go to rent a car and you have to make sure the car is right. You can't just rent any car. You have to get the right one. You can't get into any roller coaster until recently they've started making some that you can get into. Of course, I'm not getting on a roller coaster anymore, but you know, they don't have many seats that some of my patients can fit in. Those things are interesting, the psychological and social factors, and they're really kind of, to be honest with you, that's kind of the fun thing about, you know, doing this. We do somebody and they come back and tell me that they rode a roller coaster with their child. You know, that's a big thing. We feel very proud of that. I have a guy who climbed a mountain. You know, he said, I never would have climbed a mountain before. You know, he lost weight and he decided to get out there and get busy and do that. That's very important, and it's fun. And we used to have pictures of all those sort of things. We ran out of room on the wall and people got jealous, so we don't do that anymore. But basically, it's a very big part of it, the social aspect of it. But that's not why you operate on anybody, okay? That's not the reason that makes you go to surgery. This is what you operate for, okay? These are the medical complications of morbid obesity. I told you that the comorbidities are the reason that insurance companies cover this. And these are the comorbidities. And if you notice, this little guy here, he's got all kind of problems, okay? From his head to his toes, from increased intracranial pressure to heart disease, lung disease, strokes, liver disease, coronary artery disease, gallbladder disease, pancreatitis, GYN problems, cancer, arthritis, gout. You know, and most of my patients could give you a list of these things because they've got those problems, okay? They're all related to your weight. And because of that, this is what you see. This is what they call a morbidity curve or a mortality curve that's brought up by the insurance companies. The reason they're interested in this, of course, they're doing life insurance, so they're betting on whether or not you die, okay? That's what insurance is basically doing. If you have a low chance of dying, they give you a better rate. And if your BMI is low, you have a lower chance of dying than if your BMI is high. If you take a patient who is 5 feet tall and weighs about 100 pounds, they have a BMI of around 20, okay? And their chance of dying every year is basically the bottom. That's the lowest chance of dying that you'll see, just based on their weight, nothing else. You take that same 5 foot tall patient and you add 150 pounds to them, now they weigh 250 pounds and their BMI is somewhere around 49 or so. You notice they're not on this curve. They're up through the ceiling somewhere, okay? So their chance of dying is a lot higher than that other person who's not morbidly obese. And that's what we're dealing with here. That's why we operate on people. That's what it all is about. That's the thing that you see. You have to have some plan for dealing with that problem if you have that sort of a risk. So what do you do for it? Well, what does your doctor do when you go to the see him? He always tells you, let's diet and let's exercise. Okay, that's what they all say. I say it. You know, everybody says it. If you look at dietary intervention and physical activity, number one, physical activity, if you don't limit what you eat, physical activity usually does not result in much weight loss, okay? Because you can overeat just about any activity you do. Dietary intervention, you can get somewhere around, 10% off in 6 months, something like that. That would be a good number to go for. But it's very prone to failure. Actually, there are studies that show at about 5 years, only about 2 to 5% of patients will keep their weight off. Okay, so it's not it's kind of a depressing thing to think just diet alone is going to do it for morbid obese patients. Behavior modification, well, that's where you go to the psychologist and he treats you and he helps you with coming back and trying to modify your behavior. And that will help, but then sooner or later you're going to stop doing that and you're going to gain your weight back. So it's very, very depressing to think about that. There are some drugs that will help. They'll typically give you some weight loss. And there are newer drugs that are coming out, but none of them are ideal and none of them have actually been shown to be long-term cures, because sooner or later you get off the drug and you gain your weight back. So the only thing that's been shown to be long-term effective has been weight loss surgery. If you look at the studies that are out there, there are some from as far back as the 1970s and 1980s that show good, sustained, long-term weight loss with improvement in mortality, okay, which is what we said is the main thing. A lot of studies, I can give you all these curves. Basically, there's a big difference between those who had surgery and those who didn't have surgery. Bariatric surgery in obese subjects was associated with a large reduction in overall mortality, and mainly that was from heart disease, lung disease, and cancer. Okay, so let's say we accept that we just talked about, and I spent a lot of time talking about that because I think that's really important. Why are we doing this? Let's say you say that you want to lose weight. Well, what's out there? Well, there are two operations we offer. There are others out there, but we offer these two because they seem to have the best results long term for our patients. Gastric sleeve, gastric bypass. Okay. We're going to go into them in a little more detail. First thing is, both operations are done through the scope, either robotically or laparoscopically, done with little incisions. We used to do them all through a big incision. We used to call this cutting a watermelon open. It's this big operation, okay? And the disadvantage of this is that you got to get over the incision. Same operation. You're doing the same operation with little incisions that you used to do through a big incision, but when you did it through a big operation, it takes you a little longer to get over it. You stay in the hospital a few more days, and particularly you can't go back to work as soon. Most times we would say about 6 weeks or so, 6 to 8 weeks with an open operation, and somewhere around 2 weeks or so with the laparoscopic. Those are general guidelines, and of course it could be different. Well, come on in. We're just getting started here. So the sleeve gastrectomy is the first one I want to go over, and I'm going to show a little video here. This is just a cartoon, so don't get too excited about it.
By cutting and stapling a thin vertical section of the stomach to make a smaller, narrower stomach pouch.
So we're going to make a banana-shaped stomach by removing about 30% of the stomach using a stapling device. And what that does is that cuts down on the amount of food that you can eat. It is something that's been around for several years now. This was an old slide that showed this, but basically what you're going to do is you're going to limit your amount of food that you can eat by removing the great deal of the stomach. Big advantages to this. Number one, you have great weight loss, okay? Most of it happens within 10 to 12 months. You get good weight loss, and we'll go over exactly what the numbers are in our group in just a minute. You're not rerouting anything, so you're not bypassing the stomach like the gastric bypass. It's done laparoscopically, like we said. The main advantage that I've found with the sleeve is that it can be done in some patients who need to lose a lot of weight but can't have a gastric bypass. That's a really big advantage, because if you've had a lot of surgery and things are all stuck together inside, you can't bring the intestinal bypass up portion of the gastric bypass, but you can get in above and slip in and do the sleeve. And that was the first patient that I did, was like that. Was a patient who couldn't have a gastric bypass, needed to lose a lot of weight, and it had a bunch of surgery, and so we could go in and do the sleeve without doing making the gastric bypass a lot bigger operation. There are some disadvantages though, and if there weren't disadvantages, this is the only thing we'd do, okay? But there are disadvantages. It is a big operation. If you ask me, you look at this and you're taking out 30% of your stomach, that's not a small operation. I would say that's a big operation. I said taking out 30%. You're leaving 30%. You're taking out 70% of the stomach. Okay, it is not adjustable or reversible, and that's probably the biggest disadvantage of the sleeve. The sleeve is something that you need to be totally in love with, because it is not a reversible operation. Okay, so you can't have this operation, have the stomach removed. We don't have a way to put that back. Okay, so it's something that you have done, and you're going to change the way that you eat the rest of your life. Very important to know that, okay? Now, having done a lot of them, I don't know why anybody would want to reverse it, okay? But still, having said that, you need to know it's not a reversible operation. It is a little bit newer, and you know, we've got patients 10 years out or so, but that is a little bit newer. The gastric bypass, which is the other operation I'll talk about, has been around since the 1960s. So we do seem to think that it is dependable and that it will keep your weight off with the concerns that we'll talk about, but it is a little bit newer than the gastric bypass, okay? So that's the gastric sleeve. The gastric bypass, I'm going to talk about it. Let me see if I can get the sound to stop on this thing so it won't work.
Gastric bypass is a restrictive and malabsorptive procedure that results in fewer
There we go. So what you do with the gastric bypass, you're going to go in, if you look inside, you're going to take the top off the stomach, okay? You're going to do a procedure where you staple and make a small pouch of the upper part of the stomach, and then you're going to bring the intestine up and bypass the lower part of the stomach, okay, so that it drains, and when you eat, the food goes through and then empties out into the intestine and is digested in a normal fashion. You don't have to fill up the entire stomach in order for people to get full and lose weight. The big advantage of the gastric bypass is weight loss, okay? And the reason that we always talk about the gastric bypass is because it's an operation that's been around a long time. You know, you've heard the term gold standard, like, you know, the gold standard. That means money is based on gold. Well, this is the gold standard for weight loss surgery because it's the one that's been around longer and it seems to be dependable. If you were going to bring out a new drug or a new way of losing weight, you compare it against gastric bypass patients. It's done laparoscopically, and like I said, it's been around a long time. Disadvantages, okay? It's a big operation, just like I said the sleeve was, okay? So you're not cutting out the stomach, but you are bypassing the stomach. You've got to sew it back together in two places, one to the pouch and one to the intestine. So you do bypass a small, short part of the intestines here. And so you have to take your vitamins with the gastric bypass. Very important, because some of the vitamins are absorbed better here. As long as you take your vitamins, there should be no major problems. But you have to make sure. We ask you to take vitamins in both operations, okay? We ask you to take the same vitamins in both operations. But it's very important with the gastric bypass to continue to take your vitamins. The dumping syndrome is something that you can see with the gastric bypass. And the dumping syndrome is a condition that can develop when you might eat something that's sweet. So let's say you decide, even though you know you're not supposed to, you go out and get a milkshake after surgery. Just try this and see how it goes. Well, what happens is when you get sugar and you put it down into the intestines directly without it being digested, it causes cramps and diarrhea. I've had patients tell me they don't want to ever do that again after they've tried it, okay? So it can be very remarkable, and it's a dumping syndrome. It causes cramps, diarrhea, and people need to run off to the bathroom. So that's the dumping syndrome, and that's why some people talk about it, and you'll hear people say that. You can even get lightheaded and other things, and it's just mainly something that you don't want to experience. And that's why some patients that try and eat sweets after the surgery, this would not be a good thing. If you were unable to change your diet and didn't go to artificially sweetened things, anything that's not sweetened with sugar is fine. It won't cause that. But things that are sweetened with a lot of sugar can cause that. Of course, that's probably has something to do why patients lose weight a little better too, to be honest with you. Because if you want to put a lot of calories in, if you eat something sweet, that's a lot of calories. Okay, diabetics understand this very well. They already, have limited sweets in their diet, and the diabetic diet was fine with the gastric bypass. Even though our patients get rid of diabetes, when they have a gastric bypass, they still don't eat sweets. Okay. The gastric band, I'm gonna mention it. Okay, we don't do many bands anymore. The problem with the gastric band is that patients do not keep the weight off as well as we'd like, and we can show the numbers, but basically most centers have stopped doing it. The Mayo Clinic doesn't do gastric bandings, the Cleveland Clinic doesn't do it, Kaiser Permanente out in California. So we've stopped doing gastric banding for the most part. It has not been a reproducible amount of weight loss for our patients. So we have had, I think in the past 2 or 3 years, only one patient, and that was a specific concern that we did a band on. So very rare to do one. And if somebody wanted a band, I'd have to talk to them a great deal and make sure exactly what their plans are for the band, because the weight loss is just not there for our patients. The Orbera balloon, that's another option out there. This is an operation, or actually a procedure, done by putting an inflatable balloon into the stomach and blowing it up. And what you do is you get weight loss with the non-surgical minimal risk procedure that's easily reversible and no staple or cutting. That sounds great. However, there are disadvantages, okay? You only can keep it down for about 6 months. So it's a good temporary solution. It is not adjustable. And the main disadvantage right now is patients don't usually get insurance coverage for it. So it's a cash pay situation. So that really limits its use for our patients a lot. That and the fact that it's temporary are the two things that we don't see patients get a lot and use the Orbera band for, Orbera balloon for. Some patients also get a significant amount of nausea, as you might imagine, with this inside their stomach. And it has to be taken out at 6 months. This would be a great thing if you wanted to lose, 40 to 50 pounds for a wedding or something like that. But it's very expensive. It costs, I think it's about $7,000 for the procedure to be done for the hospital charges and all that sort of thing. So that's the Orbera balloon. So let's talk about weight loss. How much weight would you expect to lose with these procedures? So this is a gastric sleeve in 658 of our patients over a 2-year period. Pre-op weight around 275 pounds. At 1 year about 205 pounds. And at 2 years, about 214 pounds. That's the numbers, okay? That's a large number of patients. So if you needed to lose 100 pounds, you'd expect to lose 50 to 60 pounds over a 2-year period with a gastric sleeve. That's on average. Now, I can pick out patients that have done better than that. But when you pick out patients that have done better, you know that on average, there are some that did less than that. This is the average number, and I think it's very important to know that because most patients are about that. Gastric bypass, this is a little bit over 2,000 patients in our group over a 2-year period. Pre-op weight around 300 pounds, a little heavier patients. Average weight at a year, a little bit less than 200 pounds, and it kind of sticks there at 2 years. Again, a little bit more weight loss like we talked about, 65 to 75% excess weight loss in our patients with gastric bypass. Okay? This is all of our numbers kind of put together, very busy slide. Bottom line is the taller that you see these block charts, the better. And this the tall numbers are the gastric bypass, the excess weight loss, somewhere around 60% or so. And then with the sleeve, you get up to somewhere around 55 or so, and that's what you see. And these are at 6 years, and this is at 12 years, I think. So that's all of our numbers put together, all comers, with weight loss. So if you're considering this, you have to have a BMI of greater than 35 with comorbidities like arthritis or hypertension or diabetes, or you have to be a BMI of 40 or greater, and even you don't even have to necessarily have comorbidities at 40 or greater. You have to meet those criteria and have tried to lose weight some other way. You can't just decide you want to get this morning and go in and get the surgery done. You really, it needs to be something you've already tried to lose in another way. And we also want you to be an adult because we don't operate on kids. There are some things that would contraindicate or mean that you shouldn't have the surgery done. If you have a disease that we can't control, basically. In other words, you have uncontrolled heart disease, uncontrolled lung disease, some sort of severe inflammation in the digestive tract like Crohn's disease that's out of control, anything like portal hypertension or cirrhosis or chronic recurrent pancreatitis. Those things need to be dealt with and completely stabilized before you'd have the surgery. Because this surgery is usually not an emergency. It would be something that you want to do electively after you've had all your medical problems completely controlled. There's one other thing I want to mention. If you've had a liver transplant, I've had several patients who've come in who've had liver transplants and done very well with their liver transplant, but you would not want to have us do your weight loss surgery. You should go back to where you had your liver transplant done or a transplant center to get weight loss surgery, okay? What does it do? Well, you have to eat differently after you have the surgery. You have to eat somewhere around 3 meals a day, small meals. I tell patients all the time, if you take a lean cuisine meal, heat it up, half of that's the average diet for our patients that are successful. Okay? So I have some patients come in and say, well, I want to do this, but I don't want anybody to know about it. For some reason, people don't really want to talk about it sometimes, and that's fine. I think that's good. But, when you go out to eat with someone and they eat 2 bites of something and, a bite of roast beef, a bite of mashed potatoes, a couple of bites of salad, and that's it. Either, they're either on a really restricted diet or they've had something different done. So they eat differently than everybody else. And our patients are noticeably different when they're around other people than go out to eat. So that's something to remember, that you will eat differently after these operations. That's why you lose weight. You have to wait before you drink. That's the other thing, people. You're having in the case of the sleeve, you've got about a 4 to 6 ounce sleeve pouch, and in the gastric bypass, you've only got maybe about a 2 to 3 ounce pouch. So you're only going to eat that much. You've got to drink your fluids separately from your eating. So you want to not eat and drink at the same time. Okay, and we have some patients that we have to really work with on that, but it's not a difficult thing to do. It's just something you have to think about. You also, if I had one thing that I could do that would make everybody be successful, is I would slow it down. You have to be very slow with the way you eat. I tell everybody, don't eat when you're standing up talking to somebody. Stop, sit down, put a tablecloth on the table. Get out your knife and fork. Get a small plate. Put a candelabra on. Put some music in the background. Okay? We're going to take our time and eat. Okay? You don't want to eat fast after these operations. You want to slow down. And that's hard to do nowadays. People eat very quickly. They eat with their hands. You don't want to do that. There's some foods that you may have trouble with. I was at a meeting one time, and one of the surgeons there had weight loss surgery, and he was out there, and we were kind of between the meetings. And what do they do when if you've ever been one of those things, they'll have a table with a bunch of bagels on it, and bagels and cream cheese. And so he went over there and he grabbed a bagel, and he was talking to us, and he started eating the bagel, and all of a sudden his face got red. he had to excuse himself. He violated our own principle. So you got to understand, you can't, you got to pay attention to your eating. Very important after surgery to make sure that you are paying attention to what you're doing, particularly in the early period. It gets easier after you've kind of been through it, but it's important to do it early on. Particularly is pay attention when you're eating. Exercise. Most of my patients are not exercising before surgery. That's just a fact of life. They can't because of knee, back, or other issues. But after the surgery, you've got to exercise. As a matter of fact, if you look at the two groups, those that are completely successful and those that are having problems, the ones that are having problems are not exercising usually. Now, as we said in the kind of the lead up to all this, exercise by itself doesn't usually make you lose a lot of weight. But what it does is it keeps you from regaining. Okay, it keeps you on the program, keeps you successful. So you got to do some sort of exercise, and we highly recommend the buddy system with this sort of thing, is that you get with someone who can exercise with you, so that if you're not there, they're going to call you and say, where are you? Very important. Support system. It always helps a lot with these operations. People are always asking about the affordability and how do you get this paid for. Well, most insurance companies have come around and will cover this. There are still a few out there that specifically do not cover weight loss surgery. We can help you with decoding your insurance company, but most of them will cover the gastric bypass and sleeve gastrectomy, and usually about 90 days of follow-up afterwards are covered with the surgery and your insurance. There are some insurance companies that don't cover, though, like I said, and we still have a cash pay option for patients that don't have insurance coverage. That's why we do this. It's basically a cash pay done with a insurance policy that helps to cover anything that might happen in the post-operative period. It is the same as if you were getting insurance coverage, basically. In other words, you would have the same requirements for surgery, the same operation, the coverage that we talk about with all of the different specialists, and the counseling that you get with surgery with insurance, all the wound and skin care options and that sort of thing, the fees that are related to the doctors, and then anything that might happen in the immediate post-op period up to about 90 days should be covered also. Of course, these are all details that we go over with you if you do decide to pay cash. And of course, that's the other thing. Some people ask, what's the quickest way you can get the surgery? Well, one of the things you can do is people who pay cash do get to go quicker, because you don't have to go through all the insurance approval process. I personally, if I could get it approved by my insurance, that's what I'm going to do. But if people that are wanting to do something quicker, this would be the way to do it. Minimum is that you have to be in our office 2 times to talk about the surgery. We want to make sure you've gone through this. We want to make sure all your medical conditions are under complete control, and then we would want to go back through it again before you had the surgery done to make sure that you are ready for it. We are a center of excellence, which basically is something that we applied for through the ASBMS, which is the group that helps to regulate our specialty. You have to have educational programs. You have to have a volume of surgery. You have to have both a volume of surgery in the institution and then a volume of surgery personally that you've done. You have to have a medical director and a bunch of specialties to support you. They check all of our equipment, make sure that it is basically sturdy enough for our patients. Before, in the old days, we didn't really have stretchers that would fit our patients sometimes. Now we've got that sort of equipment. We have x-ray machines. We have people that can help us with getting our x-rays. We have to have clinical pathways, so that, by clinical pathway, what that means is that the nurse that is at the bedside has been educated on what to expect. In other words, this is day one. What's this patient supposed to be doing? Well, they're educated to that. They know what to look for. Some of our nurses on the floor that have plenty of experience, they can tell us, you need to come see Mrs. Jones. She just doesn't look like she's supposed to today. And if there's something wrong, we can identify it earlier that way. That's what clinical pathways do. They also make sure that we're doing all of the steps that are necessary to make sure our patients stay safe. We also have to have continuing education. In other words, we have to go to these meetings and things like I was talking about. And we have a goal of 75% follow-up of our patients at 5 years, which is something that we're still working on. But we do have good follow-up, but it's not gotten up to the point where we're happy with it yet. Patients move around in the United States. You know, in Sweden, they have almost 100% follow-up on their patients. I think Swedes like to go back to the doctor, is all I can say. I just don't know what it is, but they have good follow-up there. These are numbers from, I think, 2017. 218 cases of sleeve gastrectomy, 123 gastric bypass, and we had 4 balloons. There were no bands done. This is our group. Why would you pick us to do that? Well, we've been around for a while. We have a lot of history with this operation, and I think that we would do a good job for you if you decide to have your surgery here. I'm going to be around. We actually are going to try and get some of our Facebook questions answered, and also some of the. We're going to probably alternate between in the audience, live audience here, and also from Facebook, to try and get some of the questions answered. One of the things that I don't think that I mentioned is that the operation, both of our operations are usually 2 nights in the hospital. Return to work, as I said, is about 2 weeks, something like that, give or take. It depends on what you do. I always tell patients, you know, they always want to know when they can drive. Basically, when you're off pain medicine and everything's going well, you can usually drive, and that varies between, you know, the first week to the second week, something like that. And it just depends on how you're doing and that sort of thing, how you feel. But the main thing is you have to be off pain medicine before you can drive. And then always make sure the 2 jobs you have after you get through with surgery, you have to drink your water and get up and move around, because those are the 2 things that prevent the problems that we can see with the operation, which would be blood clots in the legs and dehydration. That's 2 things we worry about on every patient. Those would be the things that I think are the highest risk for the operation. Do you have a question from the audience here? Anybody have any questions here? Yes, sir. How long? The question is, how long does the sleeve operation take when you do it in surgery? Usually somewhere around 45 minutes to an hour, and the gastric bypass would be about the same. So both operations would be a little bit under an hour on average, assuming that you don't have any other major, you know, problems or anything like that. I haven't had a lot of surgery in that area before, but that would be the average. Yes, sir. Let's see if we have any questions from Facebook. This is Rachel, who is our nurse practitioner, one of our nurse practitioners.
Hey, thanks for joining us. All right, so we have 2 questions so far. One is, can the stomach stretch back to normal size after the sleeve?
Okay, so that's a good question. The stomach, when you do the sleeve, what you're doing, you're basing the pouch, this little banana-shaped pouch, you're going to base it on the part of the stomach that doesn't stretch. And we haven't really seen a lot of stretching over the years with the sleeve. That's why it's designed the way it is. There were some operations done on a different part of the stomach years and years ago, and there were some stretching. There was some stretching to the pouches back then, but that's why it's been modified, and we use the less distensible part of the stomach, and you don't see much stretching. That's not the problem with the sleeve.
Okay. And Stephanie asks, can the balloon be done on a person that already had another procedure if the goal wasn't reached?
That would depend on the question is about the Orbera balloon, and that would depend on what other procedure they had done. So that would be something that would have to be looked at in the office, basically looking at the patient, seeing what their stomach looked like and that sort of thing. The balloon, you know, would not fit on some patients who've had, say, a sleeve or something like that. You'd not be able to get the balloon down there because, as I said, if it's not stretched out, there's not room for a balloon down there. So we'd want to we'd have to talk about what kind of procedure it was. I wouldn't want to rule it out or rule it in based on what we're saying. I think it's something you have to discuss with your surgeon. Questions in the room? Any other questions in the room here? Y'all been a great audience. You've paid. Nobody went to sleep or anything like that. It was really very good.
One more. Yep.
Got another Facebook question? We're getting it reloaded. You know, they got this new thing called the internet. You can get these things. They'll come over just over the magic here. It's not reloading. Yes, sir.
What if you already have issues with like acid reflux? Can it make that worse, or does it make it better? Excellent
question. Acid reflux, number one, very common problem with our patients. you know, over the overall population, about 30% of patients will have problems with acid reflux and have to take occasional medication for it. You know, but some patients have it all the time. They have complications of it and that sort of thing. So you have to dive in a little bit into what particular kind of problem people are having, and that would be something you want to look at. But basically, a lot of times we have to deal with that with the surgery. And acid reflux is something we would want to control at the time of doing the surgery, making sure the operation is tailored to help you with that. In general, what they say with the surgical literature is that most patients that have severe acid reflux would do better with a gastric bypass than with a sleeve. I'm not sure that's always true. It depends on more the anatomy in my experience. So I wouldn't want to say someone couldn't have one operation or the other, but in general, that's what is said, is that the gastric bypass is a better operation for patients with severe acid reflux.
Okay. Okay, we have another question. What are the reasons that calls for revision?
Revision. Okay, so revision surgery I could do. You know, I've kind of bent you guys' ear for a little while here, but I could talk for a long time about revisions. Revisional surgery is basically a whole subspecialty of weight loss surgery. It's something that happens when a patient who has had either a sleeve, a bypass, a band, a duodenal switch, or some other type of weight loss surgery, now they're having problems. Either they haven't lost their weight, or they're not able to eat properly, or they're having some other issue. And they come to see us, and basically you have to find out what's wrong. What is going on? What's the problem here? Is this something that is due to the surgery? You know, is it something that has the surgery failed the patient? You know, we hear about failures all the time. Well, what caused the problem? Did the surgery mess up? Is it something we can fix? So we have to look for that. We have to find exactly what's going on, what the problem is, and then we have to see what's the best way to fix it. Is the best way to fix it to go in and redo the surgery? In other words, put it back like it's supposed to be? I think everybody has talked about stretching out something. Well, if you find that something has become much bigger than it's supposed to be, and patients can eat more than they're supposed to, is it worth going back and making that tighter or smaller, making so the patient cannot eat as much? The answer to that question a lot of times is no, that really won't help, okay? Because sometimes it's not that the pouch is stretched out, it's that someone has learned to eat around the operation. You know, we're all pretty smart about how we eat. And when we put our minds to it, we really can put that square peg in that round hole, okay? So we have to make sure about why is the surgery not working. If it's something that can be fixed mechanically, yes, we do revisions. We do. I probably have done this year maybe 3 or 4. It's not very common, but we definitely will do revisions on patients where there is a mechanical issue that can be fixed with surgery. A lot of times, though, if we have a patient who's struggling, we need to go back to basics and start over again with their operation, get them back to eating properly, and get back on track, basically. And then that's the other reason that we tell patients follow-up is so important. If somebody's struggling, we need to see them back in the office. That's why we want to follow up all of our patients for at least 5 years, because basically by 5 years, you're pretty much where you're going to be. But we want to follow you up very, very thoroughly to identify the problems that we might see before they become 50-pound problems. You know, I tell everybody, 5 pounds, hey, that's where everybody in the United States lives. They have 5 to 10 pounds they want to get off or deal with all the time. But when you start talking 20, 25, and then pretty soon you're talking about 50 pounds, and then that's a lot harder to deal with. And those, you know, you're trying to change habits that result in a 50-pound weight gain, that's going to be tough. If you're trying to talk with the 5 or 10-pound weight gain, then we can usually deal with changing habits. So revisions, whole big topic. I would not want to be able to answer that with just a very short answer, because it's not a short answer. It's a very long answer. It's something you have to go back through and look at very carefully.
Can you take too many vitamins?
Yes, you absolutely can. You can take too many vitamins. The problem with vitamins is that some of them are what we call fat soluble, and some are water soluble. The water soluble vitamins, basically like vitamin C, you know, I wouldn't want to tell you could take as much as you want to, but you can take a lot of vitamin C and it just washes through your system. It makes the makes the fishes in the ocean healthy. You know, they won't just go out through the system. But the fat-soluble vitamins, like some of the vitamin A, D, and K, those stick around. Okay, so you don't want to take a lot of those. They can build up in your liver, so you do want to make sure that you're taking the proper dosage of these things. And also, you want to make sure you're following the patient. Like we talked about, it's really important to follow the patient and to have labs and that sort of thing drawn on a routine basis when you're taking vitamins to make sure that you don't have problems. Yes, ma'am.
Okay, I know the goal is to lose weight and everything, but what if you get to a weight that you want to maintain and like the look and everything? What do you do?
That's the old question about how do you know to stop? How does your body stop, and why don't you just disappear? You know, I mean, people have asked me that before. And, you know, what happens? You just lose weight, and all of a sudden you're just gone. Well, no, that doesn't happen. Okay, that is if someone has lost too much weight, there's a problem. Okay, we just talked about revisional surgery. That's ones that almost always need some sort of revision. If they're losing weight too rapidly, there's some sort of problem. It could be that there's a problem with the surgery. There could be a problem. The patient has developed some sort of eating behavior problem. You have to identify that problem. That's really the most important problem to identify. If somebody's lost too much weight, then we have to figure that out. Your body will reset to a new weight, though, and it does that almost magically. I have always been impressed that people will go from eating, on average, probably 2,500 to 3,000 calories a day, and maintaining their weight at a high level, bigger than they want to be, and we'll take them back down to a 1,000 calorie a day level, and they'll reset, and they still don't get really below their ideal body weight. It's very, very common that we see that. You will probably set your weight by the amount of exercise you do and about the number of calories you take in. And again, we don't see patients lose too much. Now, you know, I've had patients come in and say, well, gosh, so-and-so's sister's brother's cousin had the surgery and they just look terrible. You know, they just don't look, they look like they've lost too much weight. Well, you know, of course, I don't know that patient, and I would never talk about any specific patient to someone else. But I see much more commonly what I see is the patient, number one, you have to make sure that you're eating balanced nutrition, okay, and that you're not taking things you're not supposed to, that you're trying to do some sort of exercise, and that the other thing is that if their patient really does look bad, we need to make sure there's not some sort of problem going on. But even those that I've had families brought back in and said, this patient's not eating enough to keep a bird alive. Well, a lot of times they come in and we do their metrics, basically, check everything, and they're fine, okay? They're still not even on that, you know, we showed the curve where the mortality was increased. They're not down to the BMI of 20 to 25, which is what we'd like to see patients get to. I think that a lot of times the family's just used to everybody being a little bit bigger than they are. And so you really want to go by the numbers and not just say, this patient hasn't lost enough weight or has lost too much weight. You know, if your BMI is 20 or below, then that's something we'd want to know about. But that's very, very rare in our experience.
Okay. I don't have a question, but Sharon shared that she learned the 3 W's: water, walking, and waiting for results. So
that's a really good reminder for us. You know, because we actually have a little test we put patients through before the surgery. We ask them to take a written test, and we've got it on there several different ways because those things are very important for our patients to remember. You know, this is not really complicated for the patient. If you boil it down to the basics, if you drink your water to stay hydrated and stay out of ketosis, you get up and move around and walk and don't sit and, you know, some patients think they've had surgery, they shouldn't get out of bed. No, that's wrong. You have to get up and move around. If you drink your water and you walk and come back and see us, there's a very high chance you're going to do very well with this. We see it over and over again. You know, I usually am in the office on Thursdays. One of us is in the office every day in order to see patients that need to be seen. But you see a lot of people coming back, and the big thing is when we used to do it open, they'd be pretty sick for a little while. It would take a while, and we didn't really know back in the old days how much water your system absorbs when you lose this much weight, because as you burn up the stores that you've got, you basically got this nuclear reactor you're carrying around with you, okay? And it's all this energy stored in your body, and if you don't turn that on, yeah, you'll feel bad. But if you drink enough, your system can metabolize that. And it causes what's called ketosis, which is where these ketone bodies are released from the fat stores in your body. If you drink enough water to wash that out, you really, people tell me sometimes, I've had wives tell me they just got up at night and cleaned up the house sometimes because they just had so much energy. It's amazing how much energy you get if you learn to get this metabolism started so you can burn up all the energy you've stored. But water is a big part of that. And then getting up and moving around, like we said, is vital, because one of the, I didn't really go over a lot about the post-operative risk. We do that a lot in the office. But if you think about what the main risk of this surgery, the overall risk of the surgery is similar to what our patients undergo when they have elective gallbladder surgery. Okay, so it's numerically about the same risk. Okay, not zero by any means, but the numbers are similar. And the main risk is from blood clots in the legs moving to the heart and lungs. That's the only, like I tell people all the time, if you wanted to make a scary movie for me, it would just have a big blood clot chasing me around the screen. That's the only thing I really worry about are the clots in the legs. So that's why we want you to get up and move around. That's why we use blood thinner in the hospital. But when people go home, we don't send them home on blood thinner. And so you have to make sure you move. You cannot sit after the surgery. I could tell you stories of patients who knew exactly when it happened to them to develop blood clots. Sitting in the car, or one lady was playing bridge one time. So you got to make sure that you get up and move around and don't sit for a prolonged period of time. For some reason, sleeping at night's fine. I haven't had anybody tell me I woke up with a blood clot. Usually it's something that happened during the day while they were sitting for a prolonged period of time. That's why we don't recommend traveling right after surgery. People say, well, I'm off work, why don't I just go on a vacation? That's probably not a good idea for two reasons. One is the sitting that a lot of times we get into when traveling. And the second thing is you really need to concentrate on yourself and not on your vacation right after surgery. You need to concentrate on the things that we're going to ask you to do. Because if you do it properly, you're going to have to drink water, take an ounce of water about every 8 minutes. And that's a big job during the day if you think about that, right after surgery. You'll learn to do it without, doing it that often. But to keep an IV out, you got to drink a lot of water after these surgeries.
All right. So what do you recommend diet pills in addition to surgery to reach your goal?
So we as surgeons don't prescribe a whole lot of diet pills. Basically, we don't prescribe much at all. I have no innate prejudice against diet pills, but we don't like to add them on top of our surgery, particularly in the early stages, because most patients don't need them. And everything that we do has side effects. Surgery has side effects. Medications have side effects. We like to keep it to a simple, straightforward, new way of dealing with things. The problems, as I've said earlier, with diet pills is sooner or later you're going to have to get off the diet pills. That's why I don't recommend a whole lot of nutritional supplement type things. I don't recommend things that you buy as a diet or as a something new. I recommend that you use regular foods, that you learn to eat them in a new way is the main way that this works. You're going to learn, it's basically like you're going to go back in the high chair. Okay, we're going to learn how to eat all over again. And once you do that, if it's successful, then it's a long-term solution, and you don't have to have access to any sort of special things to keep your weight off. You're doing this without help, basically. You're self-sustaining. And you don't need any sort of supplements or pills or anything like that. We want to get you off pills, not get you off on any more pills. We have a very good rate of that. We have about somewhere around a 60% success with getting patients off diabetes medication. The same number for getting patients off high blood pressure medicine. So that's more what we're looking at, is getting off medication.
Okay. Does insurance cover revisions?
Usually we have to work on that. It depends on the insurance company. There are some insurances, and some insurances are very easy to deal with. That's not the most common that we see, though, unfortunately. We have a whole section of our office that deals with insurance, making phone calls and that sort of thing. What we have to do is we have to be very careful about the way that we look at revisions. You know, some insurance companies will only allow you to have one operation per lifetime, and that's what we stick with. We stick with whatever the insurance company requires. Sometimes it's not actually a weight loss surgery, though, that you're having the revision for. It's something else. We just have to look at that. That's really something we would have to talk about with your insurance company to see if it were possible to get it okayed. Any other questions here in the audience? We've kind of been, yeah. Questions about diets around surgery. I'm going to go ahead and include the preoperative. We have a famous preoperative liquid diet that we do for 10 days before the surgery. And we've added that in over the last few years, and it's not done as anything other than to help patients. It really makes a difference. When in the old days, we used to do this operation, and we would see the patient, we'd get them ready, and then we'd schedule a surgery in about 2 or 3 or 4 weeks. And then we'd meet them the day of surgery, and they would have gained 30 pounds. My goodness, what happened? You know, we found out that that was what's called the farewell tour. Okay, and I think that anybody who would be contemplating weight loss surgery could tell you exactly what that is without even knowing. That's where you go and eat at your favorite restaurant several times, or maybe several of your favorite restaurants. And I understand the impulse, and I understand that, but the problem is that 30 pounds that patients would gain was all put into the liver, which is exactly where we're operating. That's we're going to work behind the liver when we're doing the surgery. Whether you have any kind of operation done, we're going to be right there. And I'm not saying everybody would do this, but I'm just saying that this is something we saw a lot of, and that makes the surgery a lot more difficult, a lot more timely, a lot more potential for blood loss when you add that much weight right in the way of the operation. So we went to a procedure where we actually do a 10-day high-protein induction diet, and it's amazing. It has made all the difference in the world. Patients that were having, significant liver size that we could not really move around easily with these tiny little scopes and instruments we do, the liver started looking much more normal. And so we've stuck with that, and we do a 10-day preoperative diet that really has helped our patients. They lose about 10 to 15 pounds usually on it, which is a great kind of down payment on what they're getting. And then they also learn a little bit about what we want them to eat after surgery. And so it works pretty well for us. Most people after the operation will gradually get back into eating solids or regular foods over about a 3 to 4 week period, something like that. They'll start off again right after surgery where we've operated. We want them to start on a liquid diet, and then gradually our dietitians will work with you by getting you back to softer foods and mushy foods, and then back to regular chewable foods. There's still may be some things even after that initial month or so that you used to like, but you don't like it anymore. So it may change your diet permanently. Great questions, by the way. And a lot of these things, we go over with you at the time you meet with us in the office. There's a lot more stuff. They actually have a class, the Begin class, that they'll go over with you that talks about some of these other issues and that sort of thing, gives you examples. They have a diet plan, and I think those are ideal. They're wonderful. We love the specifics, but I want you to be able to deal with this without any sort of books or anything. I want you to be able to, it's natural. When you get up in the morning, you're going to know what you need to do. It's not going to be something you say, well, I got to go check the internet. No, this is something that you're going to do because it's a natural way that you should deal with things. And we'll give you at least one good way to deal with this post-op. Now, there are many other ways to go through this, and I know that, but we're going to give you at least one really good way to do it, and give you a lot of advice on that one really good way. Well, we're about up on an hour, I think. I'm going to hang around. We could certainly answer questions longer than this. Anybody that is here in the audience and you're here because someone told you you have to go to a seminar, you've done it. You've graduated. Your degree is held. I will certainly be around to answer any questions that might come over the internet, and I think we have plans to do that even longer. If people have written questions or something, we could respond to. What I would say the next step is, if you're interested in this, we would like to meet with you in the office, go over your medical history, talk about what needs to be done next, try and get your insurance approval process started. That's usually not quick, I'll tell you that. You have to see what they say and get everything, all the I's dotted and T's crossed. Thank y'all very much.